Next up, we have Dr. Lori Adams with Cognivue.
All right, so today I want to talk a little bit about practicing ear to brain, including cognitive screenings and a listening and communication needs assessment. How many in the room are doing cognitive screening right now? Show of hands. Good amount. I love it. I love it. Of course, our disclosures, right? I am a consultant for Cognivue. I used to be a full-time employee with them, running their clinical sciences, education, and training. I have no other disclosures at this moment. And why perform cognitive screening, right? MCI and dementia are expected to triple by 2050. And as I always like to say, it's the responsibility of all licensed healthcare professionals to be conversant in major health concerns such as diabetes, cardiovascular issues, cognition, suicide, and more. And why is that, right? It's not that we're going to be experts in treating that, but how do we manage that patient, either in our practice or with, multidisciplinary team approach? For example, our diabetic patients, right? Do they have neuropathy in their fingertips? Is it going to take a couple extra visits to help them to be able to get that hearing aid in and out, to get it on the charger, right? I used to be very big in tinnitus when I practiced, and I had about 2 or 3, I think, in my career, where I had to contact the primary care physician because of suicidal thoughts and concerns for that. And then cognition, right? Is that patient going to need additional supports? And how can we tailor their treatment plan to help them? And do they need more support? Candidacy for cognitive screening. Symptomatic adults 55 and over who have a family history of MCI dementia, speech and noise complaints, memory concerns, inattentiveness, vestibular concerns, polypharmacy issues, and of course more. We do know that it is being used in younger populations as well for cochlear implant candidacy now. So I like to kind of get back to like the foundation of it, right? What's the difference between hearing and listening? Hearing is simply just detecting a sound or perceiving a sound, right? Oh, there's a siren. We don't know what that is. Listening is actually assigning the meaning to sound. Comprehending the sound. Oh, that's a siren. It must be an emergency vehicle, right? Actually comprehending that. It's all about the brain. We can make almost everyone hear. We just can't make everyone listen, right? So I like to look at it as a big picture, right? A lot of our offices are just doing a basic audiological workup, doing an audiogram, and that's really just getting to the part of our patient's hearing levels. When we bring in that listening and communication needs assessment, that whole comprehensive evaluation with questionnaires, an AFAB, a COSI, an HHIA, an HHIE, and more, speech and noise testing, cognitive screening, and additional audiological testing, we're really getting to the heart of what our patient's individual needs may be. So how does this impact patient care? First, we can rule out if cognitive issues are a primary concern. If it's a non-normative result, we can refer on to their primary care physician to investigate further. It allows for more tailored treatment plans for our at-risk patients, right? Do they need some oral rehab? Do we need to partner with a speech-language pathologist in the area? Memory clinics, online language and memory training programs. And then, of course, hearing aids, pocket talkers, FM systems, digital remote mics, loop telecoils, assistive devices, any way we can help. I still remember a patient who she had been diagnosed with Alzheimer's, and she was on a day treatment program, and her husband spent every time when she was at that daycare program looking for her hearing aids because she would hide them. And so finally we're just like, let's get down to basics. Let's do a pocket talker. So how can you help those patients improve that? What are some common issues with current cognitive, our pen and paper tests, the MOCA, the SLUMS, the MMSE? You have to have trained staff to administer them and score the test. There's possible human error in the scoring process that may lead to inaccurate results. Lack of consistency when used across multiple sites. Low test to retest reliability, and multiple associated biases. And so that's where the solution of Cognivue Thrive comes into play. A little bit about Cognivue's history. In 2005, it was started as Cerebral Assessment Systems in Rochester, New York by Charles Duffy, who is a neurologist out of the University of Rochester. He got NIH funding for research that led to the first generation technology. It took 10 years, and they received their FDA 510 Class 2 de novo of the first Cognivue device. In 2018, it was acquired by Tom Golisano and renamed Cognivue, and they launched the Cognivue Advanced device. In 2020, they launched the Cognivue Thrive and Clarity devices that they have today with a low profile. In 2022, they completed a 1,500 patient focus study, which is going to enhance the normative ranges to set a new gold standard for sensitivity and patient profiling. And in that study, they had 18 and above, so more age-specific norms. Why is it different? It's more sensitive, better test-retest reliability. It eliminates the bias, human error, and variability. Motor ability and visual acuity are factored into the calibration, as I'll say in a moment. So we know that we're doing a pure test of cognition. It's capturing 78,000 data points in one single test. That's data captured every 83 milliseconds. It's simple and automated way to evaluate cognition in an audiology clinic. It's 5 minutes. It's objective, self-administered, so you can set the patient up and they can just run it themselves. It does not rely on auditory stimulus, which as an audiologist I love, right? So we know that we're testing cognition separated from hearing impairment. It's an automated report, so you don't have to worry about scoring it. And it may lead to earlier audiological intervention and physician referrals. As we know, the industry standard is 7 to 12 years from when someone thinks they have a hearing loss to when they treat. But if we're educating them more about the ear to brain, it's not just this widget that goes on your ear, right? There is more to it. I think when patients are, educated from that standpoint, they're more likely to move forward. So what is the science behind it? So Cognivue uses what's called adaptive psychophysics. So what it does, the subject can detect a stimulus, identify it, differentiate between that and another stimulus, or describe the magnitude of that nature of that difference. Those responses are independent of socioeconomic status and their educational status. So Cognivue uses the patient responses to dynamically change and adapt that test to determine their thresholds or failure points for each patient. They hold patents on the technology, so our Cognicover is what helps with eliminate distraction and light interference. The Cognivue has a 1 degree of freedom, therefore minimizing all variance. And if anybody's ever used it, sometimes the patients are like, is this wheel broken? I always tell them it's setting up to you, to your own individual needs. And then our whole Cognivue system, the software algorithm and everything else that goes into providing that customized screening for that patient. So the patient experience, there's going to be a 3-minute introductory video for that patient. And then, of course, the 5-minute screening evaluation is 6 tests. It starts with adaptive motor control. This is where that wheel, I always tell the patient, is going to move too fast or too slow. That is setting up to their own motor skill ability. Visual salience testing, so it's going to give different contrast and fade out to see how bright the test needs to be for that individual patient. And a patient can fail out on these. So if they can't get through this, the test will stop. Perception testing, so we have word and shape. So it's the 30 most common 3-letter words in the English language. And they have to know which is the real word compared to the non. It is available in English and Spanish. And then shape is going to be which of these shapes does not look like the other. And then memory testing. So what it's going to do is going to flash a series of words in the center of that circle, and they have to remember the first word. And same thing with the shape. The Cognivue Thrive report is great because it gives immediate insight, very user-friendly. It's not necessary to go through the whole thing, though. You don't want to do really focus on the holistic view of everything. Where are we, concerned? Where are we not concerned? And how is that going to kind of impact treatment? And as you can see, it has 3 cognitive domains: memory, visual, spatial, and executive functioning, and 2 speed performance parameters, so reaction time and processing speed. So that really lets you know how that patient is moving through the screening. We provide physician information. So As you can see here, this is a front-back piece that you can send to physicians so that they know what you're completing, so as they start to see the reports coming in. We also provide letter templates for results to send along with your audiological report and the Cognivue Thrive report, so that you can do that. So that's provided by Cognivue for you. We also offer a Cognivue program. So this is lifestyle-related risk factors and medical conditions that can affect cognition. So what proactively your patient can do to improve their cognition. So things like staying mentally fit, maintaining social connections, which we know was hard during the pandemic. I was actually in a practice in the heart of D.C. at that moment, and I had a patient who was like, I'm not going out of the house. I don't see anybody. I'm like, I want you to read aloud to yourself 20 minutes a day with your hearing aids on, and I want you to keep them on, just to try and keep her, or call me. At that point, my practice was pretty slow in D.C. I'm like, give me a call. I'll chat with you for a little while. Anything that can keep that patient engaged, right? Exercising regularly, eating healthy. We know that sometimes with our seniors, getting enough water is very important, right? So sleep and relaxing, healthy hearing, optimal vision, and of course, medication management. So I know a lot of patients see many different providers. They might not all be in the same network, and this doctor may be prescribing something in this, and they forget to tell their primary care that they now have this new medication. So it's always a good idea to tell your patient if they're on more than 5 medications on that medication list, they should be going back to their primary care physician and just making sure they're reviewing everything that they're on. And that's it. I talk fast. Sorry.
Thanks.